Morning, good afternoon, good evening, everyone. Thank you for joining us in this webinar series entitled Health of Migrants and Refugees, Catalyzing Research Evidence Exchange between Chile and New Zealand. My name is Baltica Cabieses. I'm a professor of social epidemiology at Universidad del Desarrollo, and I will be hosting this second webinar of this webinar series. A bit about this webinar series. This series of 6 webinars aims to create a robust and rich exchange of findings and methodological practice related to the health of migrants and refugees between Chile and Aotearoa, New Zealand. Chile and New Zealand, despite being on opposite sides of the Pacific Ocean, share several interesting similarities in terms of geography, agriculture, and natural resources, marine and environmental focus, and relatively small populations with long-standing stable democracies, coming from decades of progressive policies. This webinar series is co-organized by the Center of Global Intercultural Health at Universidad del Desarrollo in Chile, which is also a WHO-PAHO collaborating center on capacity building for training and research in the health of migrants and refugees, and the Center for Migrant and Refugee Health Research at the Auckland University of Technology in New Zealand. This webinar series is also supported by multiple organizations and institutions, such as the Lancet Migration Latin American Hub, the Chilean Network of Research on Health and Migration, REGISAM, and the New Zealand Policy Research Institute. In terms of healthcare systems, Chile and New Zealand share several notable distinctions and similarities in their health systems. Chile has a dual public-private system. The public system for NASA covers about 75% of the population, while the private system, ISAPRES, serves higher income individuals. New Zealand has a predominantly public system, funded through general taxation. The government provides universal health care through the Ministry of Health and district health boards, now centralized under the Te Watu Ora Health New Zealand. Chile spends around 10% of the GDP on healthcare, whereas New Zealand spends roughly around 10% as well. Also, both countries are below the OECD average in per capita spending, but achieve relatively good health outcomes, and both countries aim for universal health coverage effectively, though access and quality can vary by income and geography, to name a few social determinants of health. Life expectancy is similar, with New Zealand slightly ahead, 82 years, against 80 years in Chile. Infant mortality in New Zealand is relatively low, reflecting strong maternal and childcare services. And both countries face challenges with non-communicable diseases like diabetes, cardiovascular conditions, and cancer. Today, our second webinar is entitled Migrant Nutritional Health and Food Insecurity in New Zealand and Chile. Evidence-based lessons and challenges. Our first presenter is Alice Blukax. She's a political scientist specialized in international migration and public policy, with degrees from the University of Manchester and the London School of Economics. She researches migration and health in Latin America, focusing on inequities in access to physical and mental health care and public policy approaches. She's pursuing a PhD at Flaxo, Argentina, and Universidad Pompeu Fabra, Barcelona, as part of the LAC EU network, a Horizon Europe Marie Sklodowska-Curie Actions doctoral network funded by the European Commission. Dear Alice, it's wonderful having you with us today. You are free to share your screen with us, and you have 12 minutes to present. Thank you so much.
Thank you, Baltica, for the introduction and for the invitation. Thank you to the colleagues as well present in this webinar and to the audience. So today I'm going to talk a little bit about food insecurity among international migrants in Chile and specifically implications for mental health. So first of all, 1/3 of the global population is experiencing moderate to severe food insecurity. So this is a top priority topic for policy makers at all levels. So the definition of food insecurity, I'm using the Food and Agriculture Organization definition, which is lack of regular access to enough safe and nutritious food for normal growth and development and an active and healthy lifestyle. Also, food insecurity has four dimensions: availability, access, utilization, and stability over time. Now, moving on to migrants. So in 2022, over 200 or nearly 300 million people were considered international migrants worldwide. This is regardless of migratory status, legal status. And there is quite a lot of recent research documenting that food insecurity happens throughout the migratory cycle. So on the one hand, it can be an important driver of migration, but also it can be experienced throughout transit and as well during settlement in a new country. So why or how do food insecurity and international migration intersect? So there are different, based on the literature, there are different factors that are specific to, not all of them, but most of them are specific to migration. Some of them are shared with the local populations as well, that mean that food insecurity may be happening during migration. So the first one, which is highly, or yeah, most of the other ones are actually highly related to that one, is migratory legal status, which in turn can condition employment, can condition income, living conditions, etc. Another one that is very specific to migrants is financial pressure to send remittances, which means that there might be less money available for different types of food. Specifically to transit, there might be lack of availability of certain nutritious food or culturally relevant food. And this is actually another important topic in migration and food insecurity, is the cultural aspect of it. So it's not just the availability just of food, it's also food that is culturally and religiously relevant and adequate. Another social determinant of health and food insecurity and migration is having support networks in terms of being able to rely on peers for other aspects, information, perhaps help, income, availability of time, sorry, for preparing food, etc. And finally, discrimination as well, as migratory status might influence all the other factors. So now diving into international migration, specifically in Chile. So since the 1990s, Chile has been an economically and politically stable country in the region in Latin America. And up until recently, it offered opportunities to obtain a residence permit on the territory, which meant that migratory processes were easy. This has changed, and as we will see, migratory trajectories have been increasingly precarious and difficult because of that. Not only because of that, but partly, and a lot of it's one of the big reasons why it's become more difficult. So historically, Chile has received immigration fluxes from different continents, but the 21st century has been characterized by mainly and increasingly mixed immigration flows from the region, Latin America and the Caribbean. So now 10% of the country inhabitants are international migrants. So that's almost 2 million people are international migrants in Chile. And the five main communities are from Venezuela, Peru, Colombia, Bolivia, and Haiti, so Latin America and the Caribbean. So in the early 2000s, the migration influxes and pendular migration patterns were mainly from neighboring Peru, but the past 10 years have seen an increasing diversification of migratory flows. So Haitian population wasn't representing more than 2,000 people in 2012, and in 2022 it was almost 200,000 people. And another key example as well, a key example for the whole region really, is the Venezuelan population, who came to represent the largest community of immigrants, growing from barely 6,000 people in 2012 to almost 800 people in 2023. So quite a significant growth. Regarding food insecurity now, so Chile is actually classified as a high-income country by the World Bank, but it's a highly unequal country, and nearly 70% of its total population is experiencing multidimensional poverty. Regarding food insecurity, so if you look here at the data in 2020, it's 19.5% of the population is experiencing food insecurity in Chile, which is way more than in 2017 when it was only 13.6. In terms of comparison with the world, it's less. So in the world, currently it's almost 30%. In Chile, it's almost 20, so it's 10 percentage point less. And in terms of the comparison with the region of South America, it's also quite less. So in 2022, in South America, it was 36%, and in Chile, 19.5%. However, I think that's what is significant and alarming in Chile is that it's grown 6 percentage points between 2017 and 2022. So I think this is, although the rate is not as high as in the world of South America, I think this rapid growth is quite concerning. In terms of international migrants specifically, so if we look at experiencing food insecurity and severe food insecurity, so on the one hand, so if you look at the numbers on the left, 19%, 28.8, and 28.6, sorry. These are the rates for international migrants, people who were born outside of Chile. And the rate has grown as well, almost 10 percentage points. And also importantly, it's higher than Chilean, so people who were born in Chile, actually. So for 2022, for people who were born in Chile, it was 18%, and for people born outside of Chile, living in Chile, it was 28.6%. And for severe food insecurity, so if we look at 2022, for international migrants, it's actually double. So from 3.2% for Chileans to 6.5% for people born outside of Chile. So quite an alarming difference as well. So now moving on to implications for mental health more specifically. So food insecurity has been found, this is from global literature and evidence, found to negatively impact mental health because it increases the risk of common mental health, but also severe mental illness such as schizophrenia, bipolar affective disorder, and mood disorder with psychotic features. But these might also be risk factors for food insecurity. So when we think about international migration and food insecurity as both as social determinants of mental health, what is the existing evidence on the global level? So together with colleagues, Baltica, other colleagues from Chile and colleagues from the UK, we actually conducted a scoping review on this. So the scoping review itself, so the protocol is already published. The scoping review itself is under review. So just very quickly, we did searches on different big databases, and we ended up including 71 articles, publications in our review. So if you'd like to look at a list of all those articles, you can have a look at the QR code. It's all in there. And this is also the evidence I'm going to, or the publications I'm basing the evidence of what I'm presenting now. So the first question we had was, how does the existing evidence link food insecurity and mental health among international migrants? So we first looked at quantitative studies, and they mostly identified a significant association between food insecurity and mental health issues among international migrants. With a few exceptions, no link was observed, but very few studies found that. And there are some contextual variability in findings. So one of the things that we saw in quantitative studies is that food insecurity was often analyzed alongside poverty and material deprivation, in general, and it showed cumulative effects with other stressors such as violence and displacement. And some studies also had or reported dose response patterns and seasonal fluctuations in mental health outcomes. Very interesting, that as well. There are also differences by disorder and population. So it can vary according to migrant group, generations, such as children, adolescents, older people, migratory status. So it's usually a bigger issue for people who are in an irregular migratory situation, for instance. Thank you, Baltika. I have 2 minutes. I'll hurry up. And then the qualitative evidence looking at the link is usually reinforcing these findings, and it often describes food insecurity as both a cause and consequence of poor mental health, shaped by post-migration stressors, and in some cases as well, bidirectional dynamics. So what are the mechanisms explaining this association? So we also did a thematic analysis of the evidence. So the first one is deprivation of basic needs, which is manifested as hunger, restricted access, and predictable food supply. Then we have a broader context of exclusion, where food insecurity is intertwined with structural exclusion, precarious employment, discrimination, etc., which generates psychological stress, feelings of powerlessness, etc., and also can exacerbate issues linked to past trauma. There's also a big cultural dimension where, as I said before, it's not only just access to food, it's also food that is religiously and culturally familiar, and not finding it can disrupt senses of identity, belonging, community ties, and things like that. And finally, very important as well, coping strategies in the face of food insecurity can have quite a big impact on mental health. So how is this evidence relevant to the Chilean case? So a proportion of international migrants in Chile do experience social vulnerability in terms of migratory precariousness, multidimensional poverty, informal employment, lack of support network. One of the things I would like to draw the attention as something that is quite under-researched is the role of individual and community level coping strategies, especially in Chile, where during the dictatorship, there was an extreme process of privatization, neoliberalization, meaning that the state still has a limited involvement, although it's been changing. And this also means that historically and syncretically, individuals and community are expected to fend for themselves in the face of adversity. And this might be exacerbated for international migrants who might not be receiving social benefits or aid from the state, or as it might be tied to legal residence, for instance, and they might not have the relevant information, etc. And also, it could be interesting to look at some of the community-based coping strategies, which might be tightening support networks such as ollas comunes, which are literally common pots, which is a type of community soup kitchen. But there is very little evidence on implications for mental health, both positive or negative, on this topic. So this is a topic that needs further research. These are the references from my presentation, and thank you so much for listening.
Thank you, dear Alice. This was a wonderful, really informative first presentation about food insecurity in Chile and how it compares with other regions, and also how it compares with its mental health effects and how much evidence there is or lack of evidence there is around that topic. So we'll now move on to the second group of presenters. First, it will be Dr. Shabnam Jalili Moghadam. She is a New Zealand registered nutritionist and a research fellow at the Out National Institute for Stroke and Applied Neurosciences. Her academic training and professional experiences span Iran, Malaysia, and New Zealand, giving her a broad perspective on nutrition within culturally diverse healthcare contexts. Her work focuses on advancing community nutrition, health promotion, and chronic disease prevention, with a particular emphasis on food patterns, eating behaviors, and ethnic differences. Shabnam has extensive experience in national and international research projects and in collaborating with diverse multi-ethnic teams. She will be joined by Professor Gail Mearns. She's an associate professor in the Faculty of Health and Environmental Sciences. Her research focuses on public health nutrition, and this translates into three key areas of research. First, community and health professional approaches to promoting healthy eating and lifestyle behaviors. Second, building healthy food environments. And third, investigations into the prevention and management of micronutrient deficiencies. Gail is an experienced doctoral and master's research supervisor. Her research expertise is in both quantitative and qualitative research methodologies. And finally, Minal Rai. She's deputy head of School of Community and Public Health at AUT. Her research interests are centered on the dynamism of consumption practices within food and health sectors that sit on the cusp of sociocultural practices and health determinants. Her research draws from and contributes to several streams of consumer culture theory research, such as behavioral transitions, migrant health, and health policy. Minal is skilled at research design and the use of qualitative research methods, including running online focus groups and incorporating projective techniques for data collection. Welcome, all three of you. It's wonderful having you today. You will be sharing this 12 minutes presentation. Thank you for being here. It's an honor to have you, and the screen is all yours.
Thank you very much for the introduction. Sorry, I think can you see my screen?
Yes, we could see it. It was fine.
Okay.
It is there now, yes.
So can you see the full screen?
Yes.
So here is the overview of the presentation that I'm going to share and pass it to my colleagues, Gail and Minal. We are members of AUT Migrant and Refugee Health Research Center, and the story of Numiwell, Nutrition, Migrant and Wellbeing Cluster, has been started about a year ago. That when Minal approached me and said that, how about coming together and work towards migrant and refugees' food behaviors and eating behaviors. And that was when Numiwell was born. And then we were putting our thoughts together for doing research studies. And that was when Gail joined us to work on a co-design study focusing on Middle Eastern, Latin American, and African. Now, here is a little bit of more conversation about migration, culture, and food. Migration involves complex life changes, including cultural adoption. Immigrants face challenges of maintaining traditions while adapting to new norms, including around the food. And food connects to identity and belonging and creates home. We know that immigrants blend their food practices with those of the host country, creating new food culture. And migration can challenge families in supporting their children's well-being and healthy eating. Here are some ethnic information about the stats related to ethnic communities in New Zealand. On the left-hand side, you can see the named ethnic groups of the ethnic communities. It's the fastest growing population group and the size of that has more than tripled since 1996, with more than 160 languages and 45 faiths represented. The community composition is with Asian, continental European, African, Latin American, and Middle Eastern. And each broad group contains many distinct ethnicities, including their food culture and dietary behaviors. In New Zealand, the last National Nutrition Survey relates to the year 2008 and 9, and unfortunately has not been updated since then. But through the Ministry of Health of New Zealand, there are some information reflected on the nutrition of the population, which are mainly focused on fruit and vegetable. And by sorting filter on the website, people can look at some of the ethnic sorting of that information as well. Just adding to a little bit on what Alice just shared with us about the food security. Based on the World Bank, it exists when all people at all time have physical, social, and economic access to sufficient, safe, and nutritious food that meets their need and food preferences for an active and healthy life. In New Zealand, the current food security measures developed more than 2 decades ago mainly focuses on economic access and doesn't fully reflect today's New Zealand culture and the context of diverse population. I would stop here and I pass it to my colleague, Gail.
Thank you, Shabnam. What I'm going to do is I'm going to overview some of the nutrition challenges and health impacts for our refugee and migrant populations here in New Zealand. So to make a start, I'm going to define what we mean by, well, what contributes to nutrition. So food practices and eating behaviours underpin nutrition. By food practices, we mean those family, social, cultural interactions around meal structure and everything around that, the timing, the frequency, the eating locations, the protocols, the food preparations, and all of those impacts on how, where the facilities available for food preparation. And then associated with that, the eating behaviours, which are those habitual behaviours around food consumption that develop over time. And these are integral to the social and cultural meanings associated with food that both Alice and Shabnam have referred to. They're influenced by food security, purchasing patterns, an interesting concept called product parity, in that the same products aren't the same across countries, as our migrants find food preparation. They're all key to health, well-being and community connection. What we want to retain is that healthy migrant effect. So how that translates into nutrition and nutrition practices is, and so this creates nutrition challenges for our New Zealand migrants. So what these challenges are, like everywhere else across the world, our food systems have become increasingly expensive. Our cost of living has increased. That's resulting in food insecurity and the need for working long hours to meet income needs. And so gradually this impacts the loss of cultural food identity and a transition to unhealthy Western ultra-processed food consumption. And this is reflected in surveys across our migrant populations in New Zealand. This has impacts for health. So what is shown is that this is increasing the malnutrition and non-communicable disease risk. What we're seeing is the double impact of obesity, but in association with malnutrition. That's coming through in our statistics quite strongly. We're seeing that healthy migrant effect dilutes over time, and this concurs with international research. For example, there's limited physical activity, low fruit and vegetable intake, an increased intake of processed foods, ultra-processed foods. We do have a problem here in New Zealand in that we're a small nation of 5.3 million with diverse cultures. So a lot of our cultural data is aggregated, and this hides the communities, the statistics for smaller communities, such as Middle Eastern, Latin American, and African populations, where the health data and the nutrition impact data can't be specifically identified from the broader aggregate data available. That indicates the need for more research for these populations. So I'll pass on to Manel now to talk about how we're going to address that.
Thank you, Gail and Shabnam. Thank you, everyone here. So what we've narrowed down is the importance of understanding and addressing those challenges as Gail has summarized for us right now. And one of the avenues to understand while simultaneously address those challenges is through community engagement and building of awareness. So like Gail said, more tailored interventions are required as opposed to aggregated ones because each community needs their own specific cultural ways of interacting with food and those values. We've also realized that providing nutrition education in multiple languages creates better awareness as opposed to standardizing them in, say, English, which could be a first or second language or third language even for people there. Practical food literacy skills are important towards teaching because life changes for a migrant here. And so there are certain habits and behaviors and practices that migrants have not been practicing in their home countries, which they need to be taught to or be made aware of to practice here. For example, label reading or the difference between carbohydrate and protein portions and vegetables and fruit portions. How about increased speed-based but healthy cooking? So those kind of practical skills are now being imparted through community gardening and cooking, where collective understanding of what are the cooking needs or what can be practiced are now some measures that are being initiated and launched to counter those challenges that we've just mentioned. But not only just community engagement and awareness, there is also, next slide, please, Shabnam. There's also need for systemic and policy level interventions. So we've just seen how Shabnam showed us that the last national data was from 2008 and 2009, which means we need more standardized data, but we also need more culturally sensitive data. We've already understood that in New Zealand, the food insecurity is more around nutritional insecurity. There is availability of food, but maybe that is what is reducing or impacting the health of migrants in terms of NCDs and cardiovascular conditions. So access to culturally healthy foods and inclusive policies and programs are important. I'll quickly jump to the last slide, which talks about what we have achieved in terms of, so the next slide, please, Shabnam. So the progress so far and barriers are that there are many regional councils, Public Health Association of New Zealand, the Asian Network, and other community groups that are working towards resolving these challenges. But the problem is that most of this approach is fragmented instead of an integrated approach. One of those approaches is our current study, as Shabnam mentioned initially. We are now conducting community conversations to co-design for an authentic understanding of dietary issues and challenges, but an integrated approach towards health interventions that are more culturally sensitive and community inclusive, more tailored education initiatives, equitable access for healthy foods through farmers markets and other local subsidizing programs, and more data-informed policy that is implicating towards all the community groups is important to counter those barriers that we see in our country. The last point that I want to make is that geographically, New Zealand has a very linear urban form that makes our logistics around interventions and programs very difficult. So as a group, we've just understood that while Auckland, our main hub, has a lot of these programs, as we move further away from those major urban areas, the quality and the intensity of these programs gets reduced. So there needs to be more research and feeding back into that. Thank you so much. We will finish with a little whakatuki as a saying in Te Reo that says, success is not the work of one, but it is the work of many. We invite you to join our Numivel cluster, and we look forward to working together on some of the common challenges that are observed in New Zealand and Chile. Thank you so much.
Thank you so much for an incredible presentation to the three of you. What a beautifully crafted, orchestrated presentation between the three of you, perfectly well with time as well. So thank you for that. Thank you for this incredible presentation, which also shares, just like Alice's presentation, evidence on what's happening, but also at the end informing about potential solutions and implementations of practice that, despite being fragmented, are sometimes giving light to what could be done and to allow to be creative and to make solutions from grassroots work sometimes could work while policy catches up. So thank you so much for that. It was wonderful. We will now move on to the comments, and we have three wonderful panelists for that. I will give the floor first to Alexandra Obach. She's a Chilean anthropologist with a PhD in social and cultural anthropology from the University of Barcelona and a master's in gender studies from the University of Chile. She's director of the Centro de Salud Global Intercultural CESGI at Universidad del Desarrollo, focusing on adolescent health, sexual and reproductive health, and interculturality. Her work bridges research and public policy, emphasizing knowledge transfer to health professionals and decision makers to improve equity in healthcare. Dear Alexandra, thank you for being here with us today. I know it's quite late in Chile right now. Thank you for joining. And as you know, you have roughly 5 minutes for your comment. Thank you so much.
Thank you very much, Valtika. Thank you very much for this invitation and this very important webinar. So, well, first of all, thank you for all the colleagues that just present. Thank you very much for both presentations, which reflect realities that are so different, yet share so many points of connection. Alice, you were the first one in present. Thank you very much for sharing your important work. Well, in Latin America, food insecurity is one of the main structural drivers of both internal and international migration. Factors such as poverty, the effects of climate change on agriculture, violence, and lack of access to basic resources prevent many communities from securing their daily food needs. This forces thousands of people, especially in rural areas of countries like Honduras, Guatemala, Venezuela, among others, to migrate in search of better living conditions. Then in many cases, migration becomes a survival strategy in the face of a system that fails to guarantee the basic rights to educate. Within this broader regional context, the Chilean case offers an important perspective on the consequences of migration and food insecurity and mental health. One of the issues that Alice has pointed that it's really very important and very interesting about her work. Alice's presentations provide a compelling overview of the intersection between international migration, food insecurity, and mental health within the Chilean context. This highlights how structural factors such as neoliberal policies, limited states' involvement, and legal barriers to social support can deepen the vulnerability of migrant population. The discussion, just to make one example of Ollas Comunes, another community-based coping mechanism, is particularly insightful, and as it underscores both the resilience and the systematic neglect experienced by these groups. Further research on the mental health implications of such coping strategies could provide valuable insights for more inclusive and effective public policies. So thank you very, very much, Alice. And well, for our New Zealand colleagues, thank you for sharing this important analysis of the nutritional challenges faced by migrants in New Zealand. It clearly highlights the complex social and structural factors influencing migrants' food practice and health outcomes. I appreciate how the presentation addresses the shift towards ultra-processed Western diets, which reflects not only adaptation, costly and less accessible food systems, but also the gradual loss of cultural food identity. The recognition of structural barriers like high living cost and long working hours is especially valuable in understanding how these contribute to health inequalities. I also want to acknowledge the point about the broad use of the Asian category, which can overlook importance of group difference and make it harder to create cultural sensitive policies. So it's encouraging to see attention called to research gaps concerning all these groups that may have that are underrepresented, and you talk about them very clearly. So all of what you present about New Zealand resonates closely with situations in Latin America, where migration is also deeply intertwined with food insecurity and changing dietary patterns. Many communities and regions affected by climate change and economic hardship face similar challenges around access to healthy food and preservation of cultural food tradition. Just as in New Zealand, migrants from Latin America often experience transitions toward more processed and less nutritious diets offered after relocating, influenced by structural and economic pressures. Recognizing these parallels underscores the importance of cultural sensitivity, intersectional approaches in both regions. Overall, this work is a valuable contribution towards building more equitable and inclusive food system for all migrant groups, both in New Zealand and globally, also in Latin America. So thank you very much.
Thank you, dear Alexandra, for this overview. It's really interesting how you were able to catch some of the most important parts of each presentation and give it back with a regional perspective, Global South, if I may, perspective on how they connect and how they improve knowledge for policy and practice as well. The emphasis on cultural sensitive food is also very interesting. Thank you. I will give the floor now to Jean-François Aguilera. He serves as Regional Health Specialist for the Americas, based at the IOM, International Organization for Migration, Regional Office for the Americas and Caribbean in Panama. His background is medical epidemiology, with various experiences of project development and implementation for different organizations and donors, NGOs, UN agencies, European Commission, private sector, mainly in Africa, but also in Latin America and Europe. Dear Jean-François, it is wonderful having you today. Thank you for your time, connecting right up from Panama with us in this second webinar. It's lovely having you. And the floor is all yours for the next 5 minutes.
Thank you. Muchas gracias, Baltica. My perspective will be mostly around South America, Latin America, and Caribbean. Unfortunately, I don't have experience at all about the New Zealand context, but it was very interesting to hear from the colleagues there, and also to complement a bit what colleagues from Chile and the previous speaker. Latin America, a bit of a context, extreme weather events, droughts, floodings, and economic instability are major contributors to food insecurity in Latin America. A recent UN report showed that at least 20 countries in the region are exposed to extreme weather events. Hunger affected in 2023 an estimated 41 million people, and food insecurity affected 188 million people in the region. So that's the global context, but we have to know that these factors disproportionately affect migrants' population, who often lacks access to stable income, healthcare, and nutritious food. So the health impact of poor diets for migrants include malnutrition, higher infant mortality, lower life expectancy, chronic diseases, mental health challenges, including psychological stress. IOM, along other organizations, intervene in the nutrition area to provide services to migrants in transit and reception settings. And the key principles of our interventions are aligned with the sphere minimum standards and include targeting vulnerable groups, special needs, and that would include pregnant and lactating women, infants, elderly, and people with chronic disease and or disabilities. Ensure that food provision meets basic micro and macronutrient needs, and that is culturally appropriate and safe. Use context-appropriate modalities of distribution, in-kind, vouchers, cash, once after analyzing risks, preferences, and market systems, and integrate nutrition services with other sectors that would include healthcare, WASH, food security, and protection. So that would give you that would complement a bit the perspective over that we experience, we face in South America, and what IOM, how IOM contributes to facilitate and to improve the access of services to migrants. Over to you, Baltica, and thank you so much.
Thank you so much, Jean-François, for that vision, and also by introducing the IOM contribution regionally to this topic, which is very significant and important to all of us. Thank you so much. I will now move on to our third and final panelist, who will be commenting also in 5 minutes. Her name is Meliana. She's a PhD candidate at the Liggins Institute, University of Auckland, specializing in nutrition and health, particularly for preterm infants. She holds a Master of Science in Nutrition and Dietetics from St. Louis University and previously worked as a hospital nutritionist and lecturer in Indonesia. Her academic journey includes prestigious scholarships such as Fulbright and the University of Auckland Doctoral Scholarship. Dear Meliana, it's wonderful having you today. Go ahead, the screen is all yours.
Thank you so much for the opportunity being a commentator in this webinar series, which is closely related to my own experience as a migrant in New Zealand. So one key message about nutrition that I got from both presentations is that migrants seemingly have nutrition resilience because they highly value unprocessed healthy food in their cooking, cultural food, and meals. However, financial struggles complicate their food choices. Of course, like the issue is more complex than that, but we can start from there. And I think New Zealand and Chile, while we're located in different continents, have different migrants from different countries, they actually have similar migrant nutritional challenges. Both countries have high level income, welcoming many migrants from low and middle income countries. I read a 2021 scoping review by Swedish researchers about food environment interaction after migration on low and middle income country immigrants in high income countries, especially in Northern Hemisphere. And they found that in general, migrants face financial struggle, high living costs, and restricted time due to hectic city life and also working responsibilities. So although they highly value unprocessed healthy food, they need to make a trade-off. And I think what we can help as like academics and also practitioners or like public health workers are like advocating them to have practical food skills, food literacy, and strong social networks. So we can advocate for food literacy programs that teach people how to read food labels and improve their understanding on what processed food really is. And I think this also is mentioned by Minal in her presentation. For example, many people receive frozen and canned food as unhealthy, even though in New Zealand, these are often affordable and nutritional options. As a migrant studying nutrition, I also began using frozen and canned foods after moving here, something that I rarely did in Indonesia, where such products are commonly viewed as unhealthy. That perception can be valid in some cases, as certain food products contain high levels of sodium or sugar. But overall, I think migrants need the skills to read food labels because frozen and canned foods can play an important role in supporting healthy, affordable eating, which is the case in New Zealand. So I think that's it for me. Thank you.
Thank you so much, Meliana, for bringing your own experience as a nutritionist and a researcher on the topic and connect that with the presentations we've had. That's incredibly useful because it brings down to earth also, just as the two presenters before and the two previous commentators. It brings down to ground knowledge and evidence into everyday experiences of choosing food, being able to buy food depending on cost and capacity of payment, but also about cultural preferences and interests. So thank you so much for that. We will now move on to our final section of our webinar for the next 10 minutes that we have got, in which I will ask all panelists to open your videos and cameras and audios as well, because I'm going to share one question and you can just pop in an answer in whichever order or raise your hand and I will give you the floor. And it's a very simple question that should drive a little bit of discussion on connecting our research and the research that has been shared here today with policy implementation. So the question is this: based on your experience and expertise, In the field of food insecurity among migrant and refugee populations in New Zealand and Chile, what measures are necessary to ensure the effective translation of existing evidence into public policy aimed at protecting these populations from food insecurity? Please identify one or two key actions that should be prioritized in this process for both countries or for your country. So if you could give an answer, a quick answer, just one pointer in a minute, that would be wonderful. Connecting research to public policy so that we move out of individuals, wills, actions, and fragmented actions into a more integrated perspectives, right? Minal, the floor is yours.
Thank you, Baltika. This is a question that I have already sort of mulled about, so I was quick to put my hand up. And I must say this outright, this is not a researched answer. It is a research-informed creative solution that me and I have discussed this with a few of my team members. We know this, that when migrants come into, say, New Zealand, there is a certain set of protocols, regulatory requirements, and induction that is connected to their arrival into the country. However, within that policy, a very simple inclusion of the mindfulness of your food challenges and of being falling prey to the healthy migrant effect could be introduced and provided with some resources that will help them start the journey. And I'm a big believer in preventive than treatment based or solutions that aim to resolve a problem. But why even let a problem start when we already have this much information? So my creative solution is, right when they arrive, a body of work that involves policy into creating that regulatory portfolio for them, to say every migrant will go through this in their language, culture, tailored to their cultural sensitivity, would be the best way forward. So here's my creative solution to that.
Thank you, Mina. Wonderful. Shabnam, please.
Thank you very much. I like to emphasize that I totally agree with Minal, and I like to add one more point, especially about New Zealand. Before we can have really impactful policies to help the migrants, we need the accurate tools to assess the need of the current population. And unfortunately, in New Zealand, we don't have those updated tools to reflect the true picture of the needs of our whole population, including migrants and refugees. So that is going to limit us to come up with a suitable advice to the policymakers that what are really the needs to address them and support the newcomers as well in the country. Thank you.
Thank you so much. Gail, please.
I'll be very quick. I reinforce what Manal and Shabnam have said. Like to add to that, we've got some amazing work happening in communities, and it's happening at a volunteer level, and it's funded by the smell of an oily rag. It's it's ad hoc funded, but they do this amazing work. They connect the communities. We need to take stock of that and need to look at how these initiatives can be better funded, because they do provide the support that the community need, but they need to be able to do that on a larger scale.
Thank you, Gail. What a great point on making sustainable what works. Thank you so much. Alexandra, go ahead, please.
Well, thank you very much. I agree with everything that has been said. Just to make a little bit of the point here, it seems to me that a necessary measure is to incorporate the principles of intercultural health into the issue of food insecurity, which is often addressed from a public policy perspective linked to poverty, but without considering the implications it has for culturally diverse groups, such as international immigrants, and also what are the implications in different aspects of health, such as mental health, but also other aspects of health. So that would be very important, I think, to incorporate.
Thank you, Alexandra. That's wonderful. And I saw everyone nodding as you were saying it. Alice, please go ahead.
Yes, thank you. I was actually going to say something about the cultural aspects. So Alexandra, you you said it before me, and I fully agree. I think recognizing the cultural aspects of food insecurity is absolutely key, especially when health teams address food and food-related issues with international migrants. And I think something that is key in Chile actually is more evidence. There hasn't been very much research yet on food insecurity and migrants. I know there has been some in the north of Chile, which is quite a migrant dense region or area, but there isn't very much yet. So I think we need to know really what the needs are beyond just the statistics of how many percent, how is food insecurity experienced by international migrants in Chile? What is happening? Why is it happening? I think that why is it happening, we cannot know. And this goes into my translation of evidence into policy. We have a lot of evidence on legal status, employment, income. So I think we should act on that. Our policymakers should act on that and promote migratory regularization, formal work, which goes together with that, etc. So I think it's a very broad recommendation, but it's what we know now in Chile. And my other recommendation is more research specifically on food insecurity among migrants in Chile. Thank you.
Thank you, Alice. That's wonderful. Going higher on structural determinants that affect not just food insecurity, but so many other aspects of everyday life. Thank you so much. I will just ask Jean-Francois if he has something he would like to add.
Yeah, I would like to add maybe that one thing that would be useful for migrants is to reduce or remove or at least reduce legal and administrative barriers to access health systems, including the nutrition services, including also stigmatization, discrimination. So well-documented barriers that still impede and or prevent access to health services or information for many, especially irregular migrants in the region, in our region, South America, but also around the world. So that would be my my contribution to what should be done. Over. Thank you.
Thank you. Thank you for raising the element, not just of structural factors, but also about discrimination, racism, and xenophobia, which is everywhere spread, and in some places even perceived to be growing in recent years. So that's a big topic to discuss and to include in policy action, of course. Meliana, I'm just going to ask you if you would like to add something to what everyone else has said.
Yeah, maybe just a little bit because everyone has already like picked like the good, like determinants to measure. But I would say we have to go to all levels of intervention. It's not only policy level, but also, maybe meso level and micro level. Let's say for micro level, we need to check their knowledge, attitude, and practice, and also self-efficacy. I think we really need to understand for each group because they have different cultures, they have different upbringings, different situation. So the information that we know probably is more like generalization, but it's good to know for certain groups. And for macro level, of course, with policy, we also need to tackle that because if the food environment cannot support individuals to improve their healthy eating, then it's difficult for each people try to improve it themselves. So yeah, it should be like multifactorial intervention.
Yeah, that's an excellent point, and it has been well researched that if you go through different dimensions and levels, then things become more effective. It's the way we create life as well. So thank you. That's a really good point. Let me end this webinar by thanking each of you for your wonderful interventions on this second webinar of our webinar series, which was entitled Migrant Nutritional Health and Food Insecurity in New Zealand and Chile, Evidence-Based Lessons and Challenges. And just as we're finishing, let me invite you to our coming webinar, the third of this webinar series, which is entitled Mental Health and Wellbeing, among migrant and refugee communities in New Zealand and Chile. Once again, evidence-based lessons and challenges. This will be happening roughly in a month from today. For Chile time, it will be Tuesday, 11th of November at 7 p.m. and for New Zealand, Wednesday, 12th of November at 12 p.m. So I look forward to having all of you connecting in the live stream, in the Zoom platform as well, and to continue this live important discussion on the webinar series that we are having. We will have 3 webinar series this year and 3 webinars coming next year. So 6 in all, divided into different years. Thank you so much again, and I shall see you all hopefully in a month from now. Thank you so much and goodbye.
Thank you.
Thank you. Bye.